Welcome, everyone. You're in the right place for Universal Healthcare for All Abilities, and we're just going to wait for a little bit to get started. We are going to record this presentation, and we also do have an AI companion helping us take notes. If you would like to introduce yourself in the chat with your name and pronouns and where you're living right now, you are welcome to, no pressure. We're just going to give it a little bit longer to see who else jumps on. Hope all of your Wednesdays have been as good as can be possible. I'm Sarah Wright. I'm with Colorado for Universal Healthcare. I do communications for us. We're going to give it just till about a couple more minutes, and then we'll go ahead and get started. We have more than 30 people registered, but as you all know, sometimes our energy level, our enthusiasm exceeds our energy level. So we'll see if we get that many on the call tonight. Again, for those of you who just joined, please introduce yourself, your name, your pronouns, where you are living right now.
You want us to do it vocally?
Sure, actually, I was gonna have folks do it in the chat, but go for it right now, Bruce, and then
Bruce Harshberger, Loveland, Colorado.
nice to see you.
I've been a fan of Universal Healthcare for a long time, ever since I lived in Alberta, Canada.
Wow, we need to hear more from you. Hi, Wendy. Okay, so yes, of course, eating dinner is good. We are going to ask folks who are not our main speakers to go ahead and mute. And actually, our speakers will probably remain muted till it's time for them to speak also, just to kind of decrease background noise. But please go ahead and introduce yourself in the chat, your name, your pronouns, where you're living. I'm Sarah Wright. I'm with Colorado for Universal Healthcare. We're really glad you're here. We have a good program for you guys tonight where we are recording, and Zoom is also taking notes. We're just letting folks in still. So just to give you guys kind of what to expect, we have three terrific panelists for you tonight who will give an introduction of some topics on this subject, but we really are counting on some questions and ideas from the participants in terms of what would a Colorado Universal Healthcare system need to include to ensure great healthcare for all abilities. So welcome to the new folks. We're just giving it a couple minutes while we wait for everyone to finish joining. Please keep yourself on mute and introduce yourself in the chat, your name and pronouns, and where you are living now. And this event is being recorded. So we have a wonderful MC. I think we'll go ahead and get started. We'll probably continue to have a few people join. You're in the right place for Universal Healthcare for All Abilities. So I'd like to introduce our MC, Michael Neal, who is on our board and is awesome and has a PhD and is running for office and is a CC Colorado College Tiger graduate and an all-around nice guy, Michael.
Thank you. Certainly all of that, is, perhaps more praise than I deserve, but I appreciate it. But I'm here in my capacity also as someone that has been deeply devoted to universal health care for a very long time, but also deeply devoted to disability justice as healthcare justice and healthcare justice as disability justice. So wanted to talk to you a little bit about things, not only about single payer and insurance, although I think we're going to get into that, but we're going to get into some really key things about ableism and quality of life and blocks to really good healthcare that I think are exacerbated by our profit-driven society and profit-driven medicine and our health system that is just not really very functional. So wanted to give a little bit of context here. As we know, I think all of us that are sitting here, the US healthcare system was already so broken and brutal that most Americans, are fearing the cost of getting sick rather more than they're fearing actually getting sick. Skyrocketing costs for so-called coverage are outpacing all other spending. As of last year, we are now, it is the greatest chunk of the Colorado General Fund, which is the most of what we care about in terms of how Colorado pays for what it needs. It is also one of the largest chunks in federal funding, though I think not the largest at this point. But meanwhile, our plans are paying for less and less actual health care. Medical bankruptcy, which drives Americans into poverty and homelessness every single freaking day, is on an unheard of upward trajectory, and it's unheard of as a concept in countries with universal health care. So add to that the US healthcare system that was already broken and brutal and all of those things that we described is now being taken to a wrecking ball. It's actually rather symbolic that the East Wing is being destroyed at the White House, because it's just the physical symbol of what's being wrecked in our system through things like horrific cuts to Medicaid, Medicare, SNAP, and the Affordable Care Act credits due to the big barbaric bill, as I call it, that Congress recently passed. Much of that bill will take effect on purpose after the midterm elections. We are fighting, progressives are fighting because they believe that these cuts will destroy US healthcare, both for the ACA credits that are impacting people right now, and for the Medicaid cuts that will be impacting folks later on. And on Monday, the Denver Post reported that health insurance premiums will double next year on Colorado's individual market. I'm actually hearing that from friends as well. And Sarah, I think we'll drop that article in the chat as I talk. And oh my God, I didn't actually even see this one. The administration apparently has also gotten rid of long-term care for service veterans. And now if you know service veterans, you know that service veterans are some of the highest users of long-term care that are not young folks, that are not youth and children. So our broken healthcare system is now being actively destroyed. We need to be ready with the new healthcare system to replace or augment it. I have been fighting on phone bank after phone bank to keep what we can of the system that we've got, but it's clear that it's broken. So we need to build something new. And this is Colorado's actually opportunity to design a healthcare system that will provide genuinely quality, comprehensive healthcare for everyone from birth to death. And so a little bit of background. In 2019, the Colorado legislature passed a bipartisan healthcare cost savings act that had the Colorado School of Public Health compare a couple of things. One is the universal healthcare system via a universal, via actually a single payer system with universal coverage via a current insurance dominated healthcare system with a public option added. And finally, C, the status quo. So that study, not too surprisingly, found that universal healthcare, not funded through insurance dominated healthcare, would cover everyone with comprehensive care the most extensively and by far the cheapest, saving millions to billions overall, especially and more as time passed. Last year, after 2 years of trying, we passed through the Colorado legislature a follow-up healthcare payment systems analysis bill, SB 2545, that would return our eyes to the Colorado School of Public Health. We'll analyze in-depth draft model legislation for a single payer universal healthcare payment system for Colorado that incorporates 10 essential values and 10 essential programs that we are thinking make up what we really need at the very least for our healthcare system to be functional. So, and while we do that, several organizations are currently funding the $750,000 cost of the analysis. Sarah's going to put a link to donate in the chat, but unfortunately, the legislature did not deem itself available to fund us itself, and so we're hoping to do it through gifts, grants, and donations, and we're going to get there. But this, like I said, this is going to be our opportunity to get what we really want. We need to inform the eventual legislation, though, with input from all of Colorado's communities. We already did a racial justice based healthcare webinar, and it was wonderful. And now we're doing it for folks with disabilities and all abilities. And so the purpose of the healthcare system should be to maximize the health of the entire community, to help people live to their fullest potential. So there be the context. And one further point of context is that if you guys were all aware and politically engaged back in 2016, we had the ability to pass a universal healthcare bill that we called Amendment 69. In many ways, I think a wonderful bill, but it did not have those studies attached to it. And so there was a great deal of very much legitimate fear on the part of folks within the disability community, and to some extent beyond it as well, in veterans communities and in seniors communities that already have programs like Medicaid, Medicare, and TRICARE, who were scared about loss aversion and scared about what would happen if this new program came in and they didn't have their beloved system that they had before. So it was a sad failure, but it was also, I think, a legitimate one. So that's what we're trying to get through today, is something that really covers all of our folks that we needed to cover, and so that we can tell folks, no, you're not going to lose your coverage. But let's also get some context about disability too. I think probably most of you guys have figured out, but if not, would love to have you sort of think on this. Most people are just simply temporarily able-bodied folks, or even able-minded. And though people don't like to process it and think about it, we can become disabled either as a result of age or even instantly. I had my dad become severely disabled due to a stroke in literally the course of minutes. I was in the house when it was beginning to happen. He had been talking to, I am one of three boys of his, my parents only, but he had been talking to my eldest brother and then had a stroke within literally a minute or two. So just sort of need to be aware of what that looks like, and and it unfortunately triggers a lot of being disabled sometimes triggers a lot of ableism, and it's a system of oppression that we can all experience being on both sides of. Just like healthcare, we all live in human bodies that need care. We don't know when they'll need care, but they will. We'll all get sick, we'll all get injured, we'll all age, and we'll all need healthcare. So currently, injustice exists for people with disabilities, even within our healthcare system, not only in our way that we pay for healthcare, in that we are not actually focused on healthcare itself, but focused on how to pay for it, but also within certain folks in the medical profession and the way they process things like what I will tell you about called quality of life. So providers may value some lives above others. And quality of life prejudice, really is one of the centered pieces of ableism. And I've got actually a story about it, but I'm going to get Sarah to vamp for literally 30 seconds while I take a drink of water so I can continue talking about stuff.
Thank you, Michael, for all that context. And we have a few new people who have joined. So thank you for joining us. Please put your name and your pronouns and where you live in the chat. And Michael's gonna have some water. So yeah, these are really intense times for healthcare. It was already not working. There's been a lot of moral injury among providers, and weaponized administrivia is the term, where everybody, especially providers and especially patients who need it, including when they're sick, are having to fight insurance denials and mountains of basically roadblocks that are there on purpose, because the way our payment system is set up, health insurers make more money the less care they provide. So the system is broken and has been broken. And then the big brutal bill is just taking a sledgehammer to that. So that was the context in part of what Michael started with. And we're ready. Are you feeling hydrated, Michael?
I'm feeling good. So this next story, I don't know what all of the folks' professions here are listening to us. If there are folks that are medical professionals, that are doctors, this is a story about a doctor that I'm pretty sure you would not make these mistakes, but wanted to tell you this story about what happened to me in college, because it's a story that I think happens just too often among the way our professionals sometimes see folks with disabilities. And so that story is this. When I was about 20, I guess I was about a sophomore in college at Colorado College in the Springs, I had my first girlfriend. And being a fairly diligent young man about the time, at least about certain things like safety, after the appropriate time and places and things, I wanted to get physical, and so I wanted to get tested. So here I was thinking that I was perfectly, completely clean and safe and everything is all good. But in fact, I had hepatitis C. And I had hepatitis C from a blood transfusion. We don't know exactly when, but we know that it was probably within the first 6 months of my life. I've had 18 surgeries to date up to now, most of them early, and and all of the ones that required blood transfusions were early. And they were before screening was super popular in and super necessary in the way we do medical care. So I apparently got hepatitis C. Remarkably, within those 20 years, it had not done enough to me that I even noticed that I had it. And so that was at least the one good piece. But what was not good is what followed. So we went to a fellow here in Denver, where I lived, and he was one of the leading specialists in hepatology in the nation. Brilliant man, brilliant researcher, horrible human. And I say that because when we asked what the treatment was, he told us it was this thing called pegylated interferon, and that it would cause massive flu-like symptoms for months and months. And he assumed that being in a wheelchair and being someone that had had lots of surgeries before and subject to a fair amount of painful things before would not want to go through the quote unquote burden of going through treatment like pegylated interferon. And so after a few rounds of going back and forth and around with him, we did eventually get rid of him after a few visits. And we knew that I could handle it. And it turns out that by the time I actually did get set up for treatment, treatment act protocol had actually changed. So I was lucky on both ends to be brave enough to break away from medical advice by a very ableist professional, and lucky that our medical R&D had created a medication that was an 8-week treatment and was a simple oral medication. So flash forward to a fellow who is now completely cured for many years, completely clear, and now has a PhD in international studies from the Korbel School at DU. Lost the girlfriend, which was unfortunate, but these things happen. But is now looking first was looking to potentially teach, and that may still be something in my future to be in the professoriate, but right now is looking to run for office in House District 2. So I would say that all of those things, if we add them together, lead to a fairly happy life, a fairly fulfilling life. And throw in all of the activism that I do through Colorado Cross Disability Coalition, Colorado Foundation for Universal Healthcare, our friends at Colorado National People's Action. And, I'd say that I've got a pretty fulfilling life. I also want to sort of ruminate with you guys on this quote, which actually came from that I used in my dissertation. And it's about the way a lot of folks, I think, view quality of life in terms of how we look at dignity and what that means for folks with disabilities. So I'm thinking that's going to be kind of crazy formatting, but now it's good. Whoops, almost good. So I wrote a dissertation about not only quality of life, but how we can include folks with all sorts of severe impairments as full inclusive citizens in society. And this was one of the quotes I was using in one of the chapters. And she says, pain is not the main reason we want to die. It's the indignity. It's the inability to get out of bed or go to the toilet, let alone drive a car or go shopping without another's help. Every client I've talked to, they've had enough when they can't go to the bathroom by themselves. Most of them say, I can't stand my mother, my husband wiping my butt. People have their pride. And that was Janet Good, the founder of the Michigan Hemlock Society. So let's just say that she was and is, to this very day, describing me. And let's sort of chew on what we think of as what dignity and value of life means and how we are able to think about that in terms of our healthcare practice and our practice as just fellow citizens as well. So I am going to then simply say, talk about how it's just about how to live a good life and what that would mean in terms of healthcare. And like I said, the current U.S. healthcare system has done a patchy job. Medicaid can be quite good in Colorado, especially compared to other states. It's under siege, but healthcare in general is better in nations with universal healthcare. There have been some issues in terms of in issue places like Canada with care for folks with disabilities due to funding. And so the question we're asking ourselves is if we're creating a new universal healthcare system for Colorado and can include long-term care, fix the disability poverty lock, which I can discuss later, and the false binary of abled and disabled, shouldn't we do that? And what would that look like? Right now, I'm going to belatedly, and I've been gone way too long, pass it over to my dear friend, Maddie Jacobs.
Thank you, Michael. And Michael was going to do all the context for us too. So thank you. That's why it was
Ready?
Michael, we're ready, Maddie.
Yeah, that was thank you for that. And I'm going to just kind of ride on your coattails here. I'm Madeline Jacobs. I was a family doc here in Fremont County for 30 years, country doctor, and finally threw in the towel to work on social justice, especially healthcare reform in 2017, because I really was not able to treat my patients the way they're supposed to be treated. So until 1974, disability, like for many of the temporarily able-bodied, was not on my radar. And then my athletic 20-year-old sister, Sid, was climbing, fell, and broke her back. And an interesting follow-up to Michael's story with the quote is my younger sister and I were in Italy at the time she was injured, and we received a letter with a card enclosed that was written. It was from my parents, and they had enclosed a card for my sister when she was injured so that we could see that she was alive and writing a letter. But what we didn't know is that she was paralyzed from the waist down. And so my little sister and I looked at each other and said, well, I'm really glad she's not paralyzed, because if she was, it would probably have been better if she had died. And needless to say, she went on to live an incredibly productive, active life, as some of these stories that will follow will tell you. So the scales fell from my eyes about the injustice of an inaccessible world. And when she was injured, that began my journey of expanding my perception of life in all its beauty and frailty, and becoming, in my sister's disability, became a beacon that affected my path, my family, and my life choices. So when I saw the injustices that were going on for disabled people through what my sister was going through, I began to work on this, including working on Section 504 and then the ADA. And I went to a lot of international sports events, including the Paralympics, in which my sister participated in with swimming. She set a lot of world records for swimming. She also became a sit skier, and I volunteered for the Winter Park program that Sarah mentions in the publicity for this event. And she got really interested in whitewater kayaking, and with a group of other disabled people in Boulder, which is where we were from, they began the Parapaddlers and did a lot of river trips with them. And in one of them on the Yampa River, when all the kayakers were dumped into the water, except Sid, she remained upright and was paddling back and forth, towing people out of the rapids. We also did amazing utopian island hopping trips and sea kayaking trips. And she also played tennis, and she did some basketball, and she just was an amazing athlete. She was an incredible athlete before she was injured, and just continued to do that. So my perspective is really from the point of view as a physician, as a family member, and as a friend to people who have to deal with our healthcare system. And it just has always felt like a continuous battle dealing with the bigotry of our healthcare system towards the disabled. And through that perspective, the biases of American healthcare system towards many populations, including the disabled, has become clear. And too often, my sister was told by providers that they didn't care for people like her. That's a quote. And in fact, she passed away in 2002 because of delay in care. She couldn't get care for an infection she had, and just got worse and worse, and finally she died from it. So because of the greed-based system we currently have, the disabled community is charged exorbitantly for their day-to-day needs. The obstacles are placed on essential equipment in terms of qualifying, and the cost is insane. And one example of this, well, I don't know how many of you have had to deal with, quote, durable medical equipment, such as wheelchairs and walkers and all that stuff. But for a wheelchair, for one chair, and that, there's no way to justify that other than they can get that money. So I had a patient who was a double leg amputee, and he lived in a double wide home. And his manual wheelchair was literally held together with duct tape. So, wanted to get him a new chair. And unfortunately, an unethical salesperson told him that he could get a, quote, free, unquote, motorized scooter, and this was one of the parameters of him being able to get that. He could not use it outside. He had to use it inside. That was a government regulation at the time. So basically, the bulky thing wouldn't even fit into the house, let alone be able to be used there. And yet, because he was bilked by that unethical salesperson, he could not get a new manual chair under Medicare and Medicaid regulations at the time. Another patient that I had severe lung disease, and she lived in the mountains, but she couldn't get home oxygen, even though for her oxygen saturations in the clinic, which was 2,000 feet lower than where she actually lived, were 60 to 70% on room air, the normal being 90 to 100% in Colorado, because she didn't live in the catchment area of oxygen providers. And unfortunately, these stories just go on and on. I'm just going to leave you with these because we have limited time here. So our system is broken. The goal of our system is profit, not maximizing the health of the people. And we are long past the time to change this paradigm. Universal health care is being done around the globe at half the cost Americans pay with better health outcomes. And anyone who says, quote, it can't be done here, unquote, are either ignorant or ingenuous. Yes, it can be done here. Thank you. And I will go ahead and pass it along to Megan.
Thank you so much. Megan Lovelace.
Hi, everyone. My name's Megan Lovelace. My pronouns are they, them, and I'm coming to you live from Leadville, Colorado, here in the mountains. I come to my disability growing up in an orphanage in Chicago, and I was born with multiple invisible disabilities that were not identified. And I didn't even know you could get help for disabilities like mine. And when my daughter was born with a disability, I was unaware of how difficult it was to obtain health care for a child with a disability. I have been serving in a public policy role for years and used that knowledge to hopefully shift some systems. But what I've learned along the way is that the systems were never really created for folks like myself or folks like my daughter, both of us having an invisible disability. In job interviews, people say, I don't believe you when I disclose that I have a disability. And if they do believe me, I am thanked for my time, and then they move along to another candidate. When I think about using Social Security disability, I think to myself, gosh, I don't want to have a limit on how much money I can make because I'd like to go out into the world and get a job and contribute just like everyone else. And when I think about having to have my job and my health care attached, I know that's not feasible for someone like me with a traumatic brain injury, and my ability to work looks different than somebody else's. And so looking for healthcare for me and people like me becomes sort of the impossible task. When you think about people who struggle with their mental health and other disabilities that you can't just see by identifying them with your eyeballs. You can't believe how many times people just refuse to believe you're disabled. And so navigating housing, childcare, education, as well as the healthcare system, really creates so many barriers that a lot of people like me tend to give up. They stop looking for meaningful employment. They don't think that home ownership is ever within their means. They may not even have children. And after my first child was born, when they handed her to me in the hospital, they said, you know, people like you don't have babies. And they offered me a free tubal ligation. Don't worry, you won't even have to pay for it. And then you won't have to worry about ever becoming pregnant again. As if it had been an accident. I have 3 wonderful children, and I'm so happy to be a mom. But I should be able to be a mom just like anybody else, even if I have a disability. Although even seeking health care for maternity and prenatal and then afterwards postnatal, I was reminded by all my practitioners over and over again, hey, you know, someone like you is going to experience challenges. And so the hospital called child welfare on me, the school called child welfare on me. All the while, I kept thinking my doctor must have my back, right? My doctor's going to tell him how great I am. Not so much the case. But when we have a system that's profit driven, like the one we do today, it's sort of expected when you think that the goal is the money, not the people. When you think about universal health care only working for certain kinds of people, I believe that it can work for all of us. When some people might say that people with disabilities cost a little bit more, I like to say it's because we're just that much more awesome. And when you have a system, a healthcare system that truly is accessible for all of us, it balances itself out. I believe that the work that the people on this call are doing and the work that the people across Colorado are doing towards a system of healthcare that is truly accessible, that's possible. And as we all know, disability is the only club you can join for free at any time. And so, whenever we think, well, my healthcare won't be like their healthcare, it's our healthcare. It's every one of ours healthcare. Whether we don't need it at all or we need it every single day to live our lives. And to the point of moral injury, when you become a practitioner, you become a practitioner because you are called to help people. And so I believe we have the will of the entire community, practitioners, business owners, everyone across the state who knows that healthcare is the baseline for living a good life. And in moments where I haven't had access to that healthcare, like today, we're not able to live our full, beautiful lives. And all of us deserve to live those full, beautiful lives. And universal healthcare is the way we're going to get there. So in the chat, we hope y'all share your creative solutions and ideas. We hope you contribute to the campaign so we can raise that money, so we can get that research. So when we come back to the legislative body, we come back with some great ideas for things that work for all of us, and especially for people with disabilities. There are so many of us out there across the state with so much to give that you may never meet, that you may never know all of the things you missed by not giving the opportunity for people with disabilities to live full lives, to have businesses, to raise families, to be doctors and legislators. All of that's possible, and universal healthcare can help us get there. Thanks for being on the call tonight.
Well, thank you so much, Megan. So thank you. We'd like you to put any questions that you have. I'm just gonna, brilliant. Yeah, that was incredible. Thank you, Megan. I'm just spotlighting myself very briefly just to say that we really would love to have our panelists answer any questions you have. And again, we're really looking for feedback to give to the Colorado School of Public Health as they do their analysis on draft model legislation for a universal healthcare system for Colorado about what it would need to include to ensure great healthcare for people, Coloradans of all abilities. So I'm going to stop spotlighting myself, and Bill's going to help me read the chat, and the panelists are standing by. And yeah, I don't see a whole lot going on in the chat. If you don't have questions and you don't, oh, here we go. Mm. Oh. Wendy says, it's just nice to be in community, having been gaslit, treated poorly by this country, and no, I'm not the only one who feels this way. It makes me sad, but not alone. Thank you so much, Wendy. Yeah.
Mm.
Yeah. The goal of all of our systems, healthcare and education, should be, and all of them should be, to bring out the potential in every single one of us. So
Again, if I might add, just think of what we can do with all the money we save if we really are getting rid of some of the silly bits that we all spend our money on now, if we're not living paycheck to paycheck because of medical debt, if we're free to get out of the cycle of poverty we're forced into as people with disabilities. all of that free flowing capital can go to different places and really grow our communities in ways we'd all like to see it grow.
Yeah, thank you. Diane asked,
Go ahead.
you can say it, Bill. It's probably better.
Okay, yeah, we have a question from Diane Dunn asking, so how we can assume that the continuum of care for long-term care, from simple personal care through nursing home facilities and hospice, that whole range of care will be included in the universal healthcare payment system.
Um,
Who
well,
would like to take that?
yeah. It is,
I'm sorry, Bill, I missed the beginning of your question.
It's how we can assure that we have the continuum of care that's needed for people with disabilities and for people with abilities and disabilities.
Do you understand the term of continuum of care? So what I'm talking about is with disabilities, there's like, for example, when I had my accident, I needed someone at home with me right after the accident to make sure I could get to the toilet and get my meals prepped, etc. That's a lower level of long-term care need than if you need to go into assisted living or go into a nursing facility or have personal care every single day to get you out of bed and toilet you and transfers, etc., etc. There are different levels of long-term care. And one of the things I'm worried about is that when people think of long-term care, all they really think about is nursing facilities. And it's so much more than that. As you know, Michael couldn't be here without making sure that there are people who help keep him in his home. Megan wouldn't be able to survive without being able to be, thank you, very proactive for herself and saying, no, I need assistance because I have this disability, even if you can't see it. There are things that we need to be able to do to support the full long-term care need for anybody who has any type of disability. In addition to what we've asked the School of Public Health to do, what can we do to assure that all of those needs are covered in any universal healthcare program?
So I'll take a shot at this, Diane, and I'll take a shot at this, not giving a for sure answer. But the answer that we can give, I think, is a couple of, it takes a couple of steps. One is that any implementation bill that is being studied has the 10 essentials behind it and has the 10 essentials as the core of long-term care, being a continuum of care, being something that, like you said, Diane, is, from your accident to my daily needs, 4 times a day, people coming in for, about an hour per shot. Sometimes it's easy things like feeding me. Sometimes it's going to the bathroom and going to toilet and getting a shower. And part of it's why I joined this board, is that I didn't know if that voice was going to be something that was heard much from. And so one of the things is that we can, look at is the 10 essentials and look at our model legislation. The other thing is that, I think that Diane, you've got a right to be concerned because we are sitting in a state, of Colorado that is sitting on a self-induced, hamstrung economic system that we lovingly call the Taxpayer Bill of Rights, and it doesn't allow us to grow quite the way we'd like to grow. And so would I have loved to have seen a powerhouse economy that would be 5th in the world if it were actually a separate country? Would I love to have seen California be the first to show us that this would work and to show that an economic system that really had that powerful engine would work? I would love that. but that's not the world in which we lived. And we can't just sit around on our butts here in Colorado watching the old system crumble around us. So we've got to at least move forward trying with the 10 essentials here in Colorado.
Thank you, Michael. Maddie?
Yeah, my video on is because you're all freezing. So it's my rural internet. I think that I tend to be simple-minded, and I always go back to why do we have a healthcare system? And unfortunately, the reason we have a healthcare system in this country is to maximize the profit of people who are middlemen and do not even provide healthcare directly. And they are getting all the money of our healthcare system. One of the most common questions that I get is when I bring up things like taking care of disabled people or long-term care or whatever, I'm told, well, we don't have the money to pay for that. Well, we probably do, because all the countries in the world that have single-payer universal healthcare systems, or just universal healthcare system using other things like the Bismarck system, is they pay only half what we pay per capita in this country, and they are getting better care. And we are actually in a situation where we may be able to build a healthcare system from the bottom up with the foundation of maximizing the health of our people, not maximizing the wealth of very few. So I think that we really need to look at it that way. And when we do redesign the system, which is what this analysis is trying to assess, is how do we do that? And that would include taking care of all of our population, including disabled people. So that's the way I think it's really important.
Thank you, Maddie. Virginia?
Thanks. I think a question at one point was, how do we do this? How do we provide good care for folks who need it? And I'm remembering during COVID that there was talk of, one of the humongous bills that passed during COVID to pump money back into our system, into the economic system, not just the healthcare system. But the idea of actually paying people who are already doing the care in the home for some folks, like in taking care of our elderly parents or family members who are supporting people who need the extra care. And wouldn't that be wonderful to pay those folks and have them be in the home and surrounded by family and getting, care with dignity? So I think that's one thing that could be explored. And actually, one of the reasons that we got pushback from the Colorado School of Public Health on analyzing this is because they said it would be really difficult to get the data because so much of the care is uncompensated. Well, how about if we compensate people for that? It would lift up these families, lift up communities. I hope that's something that they'll explore.
Thank you, Virginia. Walter?
Hi, Sarah.
Hi, Walter.
Greetings from Montpelier, Vermont.
Greetings.
I was on a call last night with some Democratic Socialists of America in New York State. And one guy had a good point. We were talking about the healthcare system, and he stopped us. He said, it's not a healthcare system, it's a medical marketplace system. And I wonder if that's a better way to start thinking of it rather than as a healthcare system. And then how do you turn it around? We can start turning it around into a healthcare system. Because right now it's just a big business, basically.
Yeah, good point.
If you're not, if you're not giving them profits, they don't give a damn about you.
Unfortunately true.
That's neoliberalism.
Yeah, thank you. Maddie?
Thank you for that, Walter. I heard or I listened to a really good, I don't know if any of you guys listen to William Barber at all, but he's this amazing activist and minister who works for the poor. And this particular one, he was talking about the big bad bill. And he said, it's a mistake to call it the big beautiful bill, because then you right away are conceding it being beautiful by using that term. And he added a few more adjectives than what he thought about it. So I think that's something that is really important. And you're right, Walter. I mean, we need to be labeling this system for what it is. And when someone says it's a healthcare system, we push back against that. So I think you're absolutely right. Thank you for that.
Yeah. Thanks, Maddie. I agree with you on that one.
Thank you. I wanted to just mention that I did put the link to the 10 essentials in the chat, and just since some of the folks are new to our organization and the legislative stuff, just to mention that it is written into the draft model legislation that folks on Medicaid would be covered at least the current level of benefit of Colorado Medicaid in any universal healthcare system, and we're wanting to raise the full $750,000 for the analysis to have the Colorado School of Public Health investigate how it would work to provide long-term care for everyone who needs it in Colorado on this continuum of range of what people need. And as we were beginning to do this event, Michael and I heard some from some folks in the Colorado Disability Coalition who are concerned that that in Canadian healthcare system and their Medicare system, a lot of long-term care gets funneled in directly into nursing home care, and definitely there's a lot to be looked at in terms of how people can stay in their homes, how, as Virginia said, we can figure out how to make it possible to get people the care they need without putting them in institutions of any kind, depending. So this is what we're really, it's like the level we're really hoping to get to with this analysis. And so I think we've raised the coalition of groups that are raising the money for the study are almost at 300,000. And then the study will start underway when they get to 405,000, I think, correct me if I'm wrong. And we're still working to raise the full amount so that we can get these long-term care questions really answered as it relates to our goal to provide excellent healthcare for every person wherever they fall on any ability. I see two hands. I see Elaine and then Leslie. Les.
Yes, I want to point out that in this study that's being done, that there will be an oversight committee, and that is a place where folks can observe the meetings. There'll be public meetings available with Zoom, and that's a real opportunity for whichever issue you can address directly to those people. So I think that is a real significant part of this bill.
Thank you, Elaine. Les?
Well, exactly what Elaine was talking about is what I'm focusing on as the collaborative, the advisory collaborative, because there's a organization that isn't that well recognized, I think, of the nursing home doctors and rehab facility doctors. It's called Colorado Medical Directors Association, but there's a bigger organization called PALT, which is Post-Acute Long-Term Care organization. And this is where all of these issues need to be hashed out, and they're not really very well connected with with our our little beautiful bill. And so I'm going to their meetings and trying to bring them along, and but it's complete ignorance. I mean, they never even heard of SB 25045, and so I've introduced them to that. So, and I'm going to make sure, even though they're not part of the essential people in the collaborative, that they get in there. And just one other comment, they're more institutionally oriented and hidebound by CMS's rules, and they're worried about getting paid enough for their providers, and they're stuck in the for-profit system, and they're very well-meaning people. I mean, their meetings are great, but I think we have to get uh, and some of the innovative stuff that this new organization or new named organization, PALT, has. They talk about providers smiling in institutions, learning how to smile at the patients, learning how to give the patients a choice, which is kind of like Michael was talking. You have to be trained in this innovative system how to treat people with dignity, and the problem is an institutional approach to this is just crazy. If you're in a bad mood and you're taking care of some cranky patient, you smile, that person's going to know you don't mean it. So home care, a whole different, the institutional system, which is for profit to the max, is really is one of the most regressive parts. So anyway, and without ranting too much, I think we need to include them. There's too much institutionalization is the bottom line. And if we had less institutionalization, the cost would be less because it wouldn't be driven by profit. You would pay people a fair wage to take care of their family.
That's
And
right.
the government would pay the loans. We're so innovative with billionaires how to get them more and more profit by, messing around with the system. So I've said enough, but I think if you think of it out of the box,
Yeah.
how to have, there's plenty of money around to take care of people at home instead of in the institutions.
Thank you. Thank you. So I see Eileen and then Jeff Kane.
Okay, yes, hi, everybody. Along the lines of what Virginia and Les just now were saying and Diane's question, currently Medicaid, you can apply as a caregiver for a Medicaid patient and get paid for taking care of a Medicaid patient. I had a patient who had severe frontotemporal dementia, and her daughter was her full-time caregiver. I mean, she needed a ton of care. And the daughter was able to get paid. And I believe, it's not like outstanding pay, but it's something since the daughter wasn't able to work. So, Medicaid could be somewhat of a model for the study people on, how to pay home caregivers in, a universal healthcare system for Colorado. And I think it's very doable. And I mean, the daughter, she was a true inspiration for me, this amazing care she took of her mom. Like I was a time where my mom was, failing in health, and I was like working and taking care of my mom. And this daughter was such an inspiration. It's just, you get really good care from family, typically, sometimes, I guess, not always. But I think, there's a model out there that, whatchamacallit, the Colorado School of Public Health could sort of look at and take off on. That's all.
Great point, Eileen. Thank you. Jeff.
Thanks. I think what we're seeing is what happens to people with challenges when two things intersect. One is the wealth care, not healthcare system that we have that's aimed at maximizing profits, and the other part is the unrecognized internalized ableism inside the healthcare system. And I'd like to share a little bit of a story and maybe two suggestions for that. I learned about disability by accident. And when I say that, it's because I woke up in the ICU 30 years ago of the same hospital that I was practicing in, spent 2 weeks on a ventilator, 2 months in the hospital, and I wear two prosthetic legs, and have had my career with that. One of the first things I discovered is that insurance companies cut out the benefit for prosthetic legs, which is crazy because prosthetic legs help you practice medicine, teach school, go get married, go to your church and work, and those kinds of things. But it's a classic example of something that's individually expensive that didn't have a large advocacy network. The good news is that we've worked towards helping pass state laws, but still, most people are still challenged. If you have Medicare Advantage, it's really hard to get a prosthetic leg. The other thing is that as I acquired a disability, I learned about the culture of people with disabilities. And gosh, it was really hard to join that group with my ego as a straight, heterosexual, athletic white man to have to acquire this new term called a disability. And one of the reasons that is because of an amount of internalized ableism that I think that we don't recognize in amongst ourselves, just like other kinds of isms. If you look at the amount of people with a disability in the United States, it's about a quarter of the population, according to CDC. If you look at the number of people graduating from high school with a disability, it's about 11, 12%. If you look at the number of people that graduate from college, it's about 11%. If you look at the amount of people that are admitted to medical school, it's 0.56%. 5% if you're more generous with your definition of disability. So we grew up with a kind of a macho school of what it means to be a physician without having people next to us that have disabilities in a way that we use a medical model, not a social model about what disability is. And when you study physicians, they have a higher fear of death and disability than the population. And they have a higher fear of higher internalized ableism that's mostly unrecognized. That's where we heard talk today from Megan and other folks about how physicians don't appreciate the quality of life of a person that has a disability. So I think that the two suggestions I would have is that one part is changing the medical education complex. Even the AAMC, the American Association of Medical Colleges, says that we're not living up to the ADA in medical school. We're blocking people to coming in medical school that have intellectual or physical disabilities would make great doctors, but our technical standards and internalized ableism don't allow them to get in and make it really hard for them once they're in. And secondly, I think as we talk about designing a healthcare system that's effective, I've been 35-year member of PNHP, that includes everybody, that we include the voices and people with disabilities in those designs, because the way their perspective is different inside the healthcare system as a complex user potentially. So those are my two suggestions for us as we think about that people with disabilities should be welcomed as part of the healthcare team, nurses, physical therapists, doctors, and secondly, that we include their voices in designing the system. Let me rephrase it, not their voices, our voices. Sorry.
Thank you so much for sharing, Jeff. Really, everyone, this has been awesome. We're learning from everyone, and I'm trying to take notes. One of the reasons we asked you to put your good ideas for what it would take in the chat is that's just a way to make sure we have them all in writing. But I'm trying to also take them down, and so that I can include them all. And thank you. It's so awesome. It's so great you guys all came, and we really, if you have other thoughts about this question, what would a Colorado Universal Healthcare System need to include to make sure it provides awesome care to people of all abilities? I'm going to put my work email in the chat. If it's fine to just send me an email. Megan, I see your hand up, or it was up.
Yeah.
I was just going to ask if we could have your email so we can continue to share all of our great ideas. And I wonder if that's on the website as well, so that we may have so many great ideas and maybe they don't all need to go into your inbox, but we want to make sure that we're hearing from across the state all of the amazing folks that have things to contribute in this space, who are I prefer the term robust self-advocates to high utilizers. We know what we need and we know when we need it. So who better to hear about a system that works from the folks that use it?
It's so awesome. Thank you, Megan. I see Virginia and then Maddie.
Thanks, Sarah, and thanks, Megan. I will share with you that in conversations with the researchers who are doing the work in the Colorado School of Public Health, is that they are eager to hear from folks like you. And we said, well, how should we do that? How can we, reach out to you as you do your work, even if we're not in the analysis collaborative that is supposed to be advisory? And what Travis Laker suggested, and he's, kind of the interface between the researchers and the rest of us as activists, is that if each of our organizations, like we're the Colorado School of Public Health, if we would gather up suggestions or questions that we want, people like you want the Colorado School of Public Health to focus on, that we gather those up and put them in a document and hand them over to the Colorado School of Public Health so that they can use that as part of their community outreach and community research that they typically do during their projects. So I guess we've got a good list started in the chat already.
Yes, thank you so much. And so do send any follow-up thoughts on email. Megan had to go feed her kids, and I'm sorry that she wasn't still here when I could just thank her for everyone, but I'll make sure she knows. She was very inspirational. Maddie.
Yeah, thank you for your comments, Jeff. And I really, the thing that has really hit me in the 50 years that I've been involved in this issue is my sister was injured in the 70s, and things were pretty primitive back then. And there was a lot of pushback at that point in the disabled community against the medical system, because the medical system was extremely resistant to making the equipment that people needed. And so really the advancements that have happened in wheelchairs and how to kayak in whitewater if you're disabled, or how to do sit skiing, it came from the disabled community, not from the medical community. And, that's the way it should happen.
100%. And I think that the communities are changing. I was just at a board meeting of Adaptive Sports Organization, and the motto is oftentimes at CCDC, nothing about us without us. And I think that's the lesson to take.
Yes.
Thank you. And this is why we held this event, is to start getting the voice of all different ability people of Colorado into this work. Of course, there's more to be done on that. You all have been incredible, and we are all growing, and we are richer with everyone participating. It's amazing. We really do better when we're all in this working on it together, and we all experience more wholeness. So thank you very, very much for everyone for participating tonight. I think we're going to go ahead and wrap it up, and we appreciate you all. Have a great night and take good care of yourselves. Thank you.
Thanks, Sarah.
We all do better when we all do better. Thanks, everyone.
Sarah,
Thanks, everybody. Great job.
Sarah, I have a question for you.
Oh, yes, Jeff.
But I'd like to do it either a direct email and not a conversation.
Okay, I watch for your email. It may be tomorrow till I respond.
I'm not certain I have your email.
Oh, yeah, I put it in the chat. S. Wright, like the Wright brothers, WRIGHT, at CO Universal.
You're part of medical professionals.
.org.
Aren't you in our database, Jeff?
I hope so.
Yeah, and I can.
think you are. So Sarah can probably get you from the database.
Ping me, and it's about donations. I thought that'd get your attention. Bye.
Bye. Thank you.